To John's apologies, my apologies for being the last speaker, and my congratulations. You're remarkably tolerant of people running over time, so thank you. I always find being the last speaker of the day difficult. Following the speakers before me is extraordinarily difficult because they have provided huge benefit to the patients with the protocols that they have developed and with the insights that they have shown. What I'm going to try and do in this talk is to provide some evidence for MIBG, but also I'm going to try and give you some insights into why this therapy works. And by this therapy, I mean the lutetium, the yttrium, and the MIBG therapies, which all work broadly in the same way. So we've seen the different radiopharmaceuticals that we can use in patients with neuroendocrine tumors. What I'm going to talk about is MIBG. MIBG can be used either diagnostically with iodine-123 as the label. That is a very effective diagnostic tool for particularly patients with paragangliomas. Iodine-131 decays by giving off a very short-range particle of radiation which deposits energy within 2 or 3 millimeters of the site that it sits in the tumor. So very similar to lutetium, a little bit shorter range in tissue than yttrium. The way in which iodine-131 works, MIBG works, is the MIBG is transported from the outside of the cell to the inside of the cell by a very active and very specific transport mechanism. So the radiation moves from the outside of the cell to the inside of the cell. Once it gets inside the cell, it decays and it, if you like, irradiates the cell from the inside out. So we have 3 different radiopharmaceuticals which are working in effectively the same way. As a diagnostic tool, it is not as effective as the peptides. I've got 3 slides which show some comparability of the way in which MIBG and the peptides take up in different tumors. So these are low-grade malignant neuroendocrine tumors. So low-grade is the black, high-grade is the white. And you'll see it's only in the low-grade tumors that MIBG is actively taken into the cell. That specific transport mechanism is lost in higher-grade, more aggressive tumors. So this is not a treatment that is going to work in patients who have very aggressive tumors. And again, this is looking at both the gastrointestinal and the pancreatic neuroendocrine tumors. Octreotide, about the same for both. And again, as John said, about 60% of the carcinoid, what were called carcinoid tumors, and only about 10 to 15 to 20% of pancreatic tumors take up MIBG. So this is not a treatment which is available for all types of neuroendocrine tumors, but it is one which is effective in those patients who have that degree of uptake. And then finally, this is looking at liver metastases in non-functioning and functioning tumors and showing the difference. So a very specific, very targeted treatment for a subset of patients. The role of radiopharmaceuticals in treating patients with neuroendocrine tumors, we've heard a lot during today. The major role in MIBG in the gastrointestinal and pancreatic tumors is in the identification of patients who would be appropriate for consideration of therapy. The other is for assessing diagnostically patients with pheochromocytoma and paraganglioma. So it does cover the spectrum of neuroendocrine tumors. So the 4 talks that you've heard previously have all described a form of radioisotope therapy. So the delivery of a very targeted radioactive isotope into the tumor cell. And we do this very specifically in a very targeted way to provide a meaningful outcome for the patient who we treat. And I've defined those meaningful outcomes. And as John said, the primary role that we have is to stabilize disease and obviously to improve symptoms and to improve the quality of life. And I think you've seen that for the peptide therapies, this is a very effective mechanism of doing this. All of the radioisotope therapies show very limited partial remission, that is, reduction of the size of the treatment and extirpation of the tumor completely. There are, I think, biological reasons for this, and I will go into those a little bit later. So the very specific components of radioisotope therapy that we need to address are as follows. The first is that it is administered systemically. So we can treat a patient who has multiple sites of tumor with one injection. So in that sense, radioisotope therapy behaves very much more like chemotherapy than it does like external beam radiotherapy. And we need to think of radioisotope therapy in the sense of a chemotherapist thinking of his or her treatments, rather than a radiation oncologist thinking of external beam radiation therapy. The second is that obviously you've seen from the images we've shown that we can very specifically target tumor sites. This obviously has advantages in both selecting patients for treatment and ensuring that the treatment has actually gone to the tumor sites. But scientifically, the most important element of this is what I've put with this incomprehensible acronym up here. It's the way in which the radiation is delivered to the tumor. When a patient receives external beam radiotherapy, the radiation is delivered from the outside in, and the unit of radiation dose is the rad. So a traditional radiotherapy treatment plan may be giving treatment every day for 2 weeks, and with each treatment, the tumor will receive 200 rads. Not important what a rad is, it's the way in which we measure how much radiation is delivered to the tumor. With this form of treatment, the tumor is exposed continuously at very, very low doses to the radiation. So instead of getting, if you like, a big bang, there is a constant trickling of the radiation into the tumor cell. And I believe, and some of my colleagues believe, that this may well explain why and how we see the responses with this form of therapy that we see. We also deliver it much more slowly. We will deliver 200 rads to the tumor not over 1 or 2 minutes as you do with external beam radiotherapy, but over 5, 6, 7, or 8 hours. So the biology of that interaction of the tumor cell with radiation is intuitively very different to the interaction of the big bang, if you like, that you get with the external beam radiotherapy. So this is a very different form of radiotherapy to the traditional way in which radiation therapy is delivered. For MIBG therapy in particular, there are two approaches. One is an approach that I favor and John Buskin favors, and indeed which Eric Krenning has also pioneered with isotope therapy, which is to give multiple doses over a period of time to try and maintain the biological effect on the tumor. The other is to give a very large dose and try and to mimic the way in which external beam radiotherapy works. This is more complex. This is, for the patient, simpler, but it involves multiple treatments to the hospital. This involves short periods of time in the hospital. This involves long periods of time in the hospital. But at the end of the day, the goal is to give as much radiation to the tumor as we safely can without causing damage to normal tissues. And I think both Eric and John gave very nice examples of how we have to weigh the risk-benefit of the treatments that we do. So when I first came to Canada about 20 years ago, one of the first things that I did was establish the MIBG therapy program. And I am very pleased to tell you that we will be introducing lutetium therapy in Edmonton sometime in the next month. My caveat is I am not yet convinced that I've beaten all the regulatory hurdles, but I believe that we have, and I have a funding mechanism to do it. So we can offer both forms of therapy going forward. So the way in which we offer our MIBG therapy is very much the way in which therapy is offered in the chemotherapy field. So we will use slightly larger doses to offer an induction therapy, and as Dr. Krenning does with the peptides, we give 4 treatments about 3 months apart. And then after that, we offer maintenance therapy. So if the patient shows a good response symptomatically or by stable disease criteria, we will then continue treating the patient every 4 to 6 months for as long as we can. And for some patients, that is a very long time indeed. So over the course of those years since we started these treatments, we've treated approximately 300 patients with a range of neuroendocrine tumors. The bulk of them have been in the gastrointestinal and pancreatic neuroendocrine group. The average number of therapies that patients now get with our new protocol is 5.2 treatments. And that is increasing quite rapidly as we become more confident with the way in which we doses. The maximum number of treatments that an individual patient has had is 16. So we have been seeing these patients every 6 to 9 months and treating them and maintaining them in stable disease. The doses are probably of peripheral interest, but the total cumulative dose that a patient has received of 3,000 millicuries is an industrial dose of radioactivity. And we do appear, by using this maintenance schedule on a 6 to 9 monthly cycle, be able to do this safely over very long periods of time. And this is the distribution of the numbers of treatments. So you can see that if we look at the number of patients who've had sort of 3 treatments or more, probably about over 100 of our patients have had 4 treatments or more, and 25 to 30 have had more than 7 treatments. So these are well-tolerated treatments. And apart from the pleasure of coming to Edmonton in the middle of winter, they're relatively well-tolerated by our patients. And it works. It works as effectively, and I believe in the same way, that the peptide therapies work. If we look at the response, and like John, we use a simple visual analog score to assess quality of life, we're seeing a response rate in terms of improvement in symptoms and stable disease of the order of 70 to 75% of the patients we have treated. Longest duration of symptom control is 12 years, median duration of symptom control is 38 plus months, and stable octreotide or reduced octreotide requirements again in about 2/3 of our patients. So we're showing the same level of response, the same degree of response, and interestingly the same pattern of response that we're seeing with the peptide therapies. And we do occasionally see patients go into complete remission, but it is rare. And this is a patient after 1 treatment, multiple sites of tumor with essentially a normal scan. These are salivary glands. This is the liver. This is a small amount of activity in the gut and a little bit of activity in the urine. So it can, but rarely, produce a complete remission. Survival, this is our survival from the first treatment. Minimum survival was a patient who had a comorbidity. Maximum survival is now almost 200 months from the first treatment. So this is, again, comparable with the data that we've seen for the other forms of isotope therapy. Does MIBG add anything to standard therapy? This is a study that Janice Pasika and I published a couple of years ago, where we compared a group of patients from Edmonton and Calgary who received MIBG with a group of patients from Australia who didn't receive MIBG, and they were identically matched in terms of time of disease, amount of disease, previous therapies. And we show this is the survival group this is the survival of the group not receiving MIBG. This is the survival of the group receiving MIBG. So there is a trend to survival benefit, as well as progression-free survival, as well as symptom control with this form of treatment. So this is looking at side effects. Side effects is mainly hematological. Patients have low platelet counts. These are reversible. Nausea is uncommon. Sorry, that was from a different paper. That's totally out of sequence. So this is data from the literature from UCSF looking at patients with pheochromocytoma. They have a much larger dose than we do, but they have comparable survival. But what is interesting, as John said in his last presentation, people who respond symptomatically do very much better than people who don't respond symptomatically. And this is shown in these, again, survival curves, people who respond and people who don't respond. And finally, there is, again, a literature on MIBG, and I'm delighted to see that John has actually published in the current European Journal of Nuclear Medicine comparable data showing comparable results. But broadly, we again see very few patients showing anatomic response and most patients showing significant palliative benefit. So what do we actually see with these forms of radioisotope therapy? Stable disease is common. We often see that patients with more tumors do a little bit less well than patients who have a lot of tumors, and that is intuitively what you would expect. But we do see a very good palliative response. I think with both the peptide therapies, particularly with lutetium and with MIBG, we have not reached the maximum tolerated dose. I think that we do have an ability to increase the number of treatments we give to maintain therapeutic response. And certainly with MIBG, we've got good evidence now that we can treat for many, many years in a maintenance sense to maintain symptom control. We've not seen unacceptable toxicity. So these are the adverse effects. So mostly we see a reduction in platelet counts. We will see nausea sometimes and fatigue very commonly. Myelodysplasia is a form of pre-leukemic syndrome, which is actually seen with most forms of cancer therapy, and the numbers that we're seeing are broadly comparable with those seen in the literature. So I think the interesting question, and I hope you'll allow me a little bit of biology at the end of the day, why does this form of treatment work? Because we're not giving it in the conventional way external beam radiotherapy is given. I think I understand why it may be working. I will say that many of my colleagues don't agree with me that this is the way that it works. But I do think that this is testable. So when we look at the effects of radiation on cells, we use something called a cell survival curve. And that is, we look at the number of, so these are looking at cells in a Petri dish or cells in a suspension in response to radiation. So these are the number of cells that are surviving associated with the radiation dose that they're given. And of course, you would expect the bigger the radiation dose, the fewer the surviving cells. With radioisotope therapy, we are operating in this part of the radiation dose delivery. If you remember, I said on a continuous basis. If you look at that part of the curve, there's a little dip. And if you put it into a cartoon, there is actually a very increased amount of cell death at this very, very low dose part of the curve. When you go back to the higher part of the curve, you go into the higher dose, lower surviving fraction of cells. So at very low doses, the radiation appears to be killing more cells than you would predict from standard biological paradigms. And this is the area of dose. Admittedly, it's continuously administered, but this is the area of dose that we're operating in with all of these forms of radiation, radioisotope therapy. So is this important? So low-dose hypersensitivity is the description of that very early part of the curve. And so what we believe is that at that low-dose part of the curve, we're actually not triggering the repair mechanisms that the cells have for repairing DNA damage. We've evolved bathed in radiation, and our cells have evolved mechanisms of repairing radiation damage. So what we believe is that we would actually see greater cytotoxicity, that is greater cell killing, at these very low doses of radiation. And this applies to yttrium, it applies to lutetium, it applies to MIBG. The other effect is that there is cell-cell signaling. So if a cell is badly damaged, it tells the cells around it that they have to die too. This is called the bystander effect. And there is a nice graph that explains this, so just bear with me 1 second. So this, if you put alpha particles through a cell plate, alpha particles only kill the cells they hit. So if 10% of the cells in a plate are traversed, you would expect 10% of the cells to die. This is that curve. So that's what you'd expect. What you actually see is that number of cells die. And there is now good evidence that there is cell-cell communication with the damaged cell, informing the cells around it that it's badly damaged, and that they should be damaged too. So they turn on their cell death control mechanisms. And this middle curve, I'm not going to go into, but this is good evidence that this hypothesis of the bystander effect is right. So all of the forms of therapy you've heard about today are actually causing more cells to die than are actually directly hit by the radiation that is administered to them. And finally, the repair mechanisms. So all cells have this ability to repair damage to DNA that is caused by radiation or other environmental toxins. We believe that the very low doses of radiation bypasses those repair mechanisms, and this proves it. So double-strand break repair is the mechanism by which the cell repairs itself. And this H2AX is the stain that we can use looking at the cell that tells us that the repair mechanism has been activated. So after a high dose of radiation, there is a lot of H2AX. So a lot of repair mechanisms are activated. With time, the repair occurs and there are less repair mechanisms activated because all the cells have been repaired. What we see at the very low doses we give with isotope therapy is in fact that there is no change in the repair mechanisms. So we believe that we're seeing two effects. One, cells are being told to die. Secondly, cells are actually not repairing themselves. And this is just another experiment that we performed in our own laboratories where we have this damage. So we have evasion at this dose of radiation of repair sensors and repair pathways. So the cells don't know that they're damaged, and so they eventually go into a pathway that is called senescent cell death. What that means is the cells become old. They don't die, and they don't die until they try and repair themselves. And so the reason that John Buscombe identifies tumors disappearing 12 months after they've had the radiation is that it's that senescent cell death is occurring when the cells try and repair. And so this biological mechanism explains what all of us have seen, which is very late improvement in the scan associated with very great early improvement in symptoms. So we have actually, with isotopes, very effective therapies. We know from the experience of the people who've come to see me, come to see John, come to see Eric. These are effective treatments. And we now believe we understand the biology of where we work, how they work. So with those two, we actually think that we're going to be able to move the field forward with the regulators and actually get these forms of treatment into routine practice so that they're not just one or two centers in each country. Finally, I will remind you that this is critical to your care, to be part of a multidisciplinary team. And remember, you're part of that team, looking after your treatment and helping us to look after your care. So the other thing with isotope therapy, I will remind you, you will be radioactive. If you're traveling across the border to the United States, you will be stopped and you will be measured. So make sure you get a letter and a wristband. So I've gone over a little bit, Jim. I apologize. Thank you for being so patient. This has been a very long, intense day. I hope you found it worthwhile. Thank you.